ladies and gentlemen, it is a great pleasure for me at this very highly esteemed meeting of CSI to also be invited to talk about management of left atrial appendage thrombus and LAA closure. Now, it may not be known to everybody that surgeons really have closed left atrial appendages incidentally when they did usually valve surgery for several decades, because it was known that if in atrial fibrillation you have embolic events, mostly stroke, but also myocardial infarctions or peripheral emboli, the embolus almost always came from the left atrial appendage, or actually always. So taking that off, of course, this risk was no longer there, and consequently, you would not have to use oral anticoagulation with all its pains. We know that for 50 years, we have had vitamin K antagonists that can do oral anticoagulations, but have a lot of problems with it. More recently, we've had the NOACs, which clearly are better than vitamin K antagonists, but still have a very poor compliance, and of course also cause bleeding. So LAA closure catheter-based techniques have been introduced by Michael Lesh and Horst Sievert in 2001. And so that's also a 20-year-old method, but it is clearly and massively underused nowadays. As a matter of fact, it should be the primary preventive treatment against embolic events in in patients with atrial fibrillation. I call that it should be used as a mechanical vaccination against these events in patients with atrial fibrillation. Vaccination is now a very current and hot topic, of course, with the COVID problem. Now, how can we prove that? As you know that there have been randomized trials, particularly with the Watchman device, comparing the LAA closure to warfarin treatment. And there has been a mortality benefit, which came out over the first years only, because initially, of course, you have front-loaded problems with an intervention, whereas with oral anticoagulation, the problems accumulate over years, but that goes on for years and years and years. So every patient with atrial fibrillation who has a life expectancy of more than a few years, which is the normal case, should have left atrial appendage closure proposed as first preventive measure against embolic events, and only if he or she cannot have it or does not want to have it, then oral anticoagulation should come into play. Now, people may argue the mortality benefit of LAA closure was against warfarin, but we're not using warfarin, you're using NOACs. But there are quite good data that even with against NOACs, LAA closure over time and already after a few years will have advantages, not only with reduced bleeding, which makes sense, but also with mortality. The question comes up, how can it be as good in preventive embolic events than oral anticoagulation? Oral anticoagulation would be better if it was used, in a perfect manner, but compliance is bad with oral anticoagulation, and compliance is 100% by definition with LAA closure. And that is why, of course, even in terms of prevention of embolic events, LAA closure stays competitive, and it's much better in not causing bleeding. So it can really not be that if you ask a patient with atrial fibrillation, have I ever heard about LAA closure, that only 1% or less ever have heard of. They should 100% be actually offered left atrial appendage closure, and only if they refuse, they should be put or continued on oral anticoagulation. Thank you very much.